Hello and good morning to everyone on a cloudy New York Wednesday. On behalf of GBC Health and our Corporate Alliance on Malaria in Africa program, I want to thank you for joining us today. I'm Ian Matthews and I direct strategy and communications for GBC Health. I have the pleasure of moderating today's session. We have 4 great speakers that will talk to us about the importance of considering an integrated approach to tackling malaria and undernutrition. After a brief introduction from my colleague Ochuko about CAMA and the work GBC Health is doing in Africa on malaria, we'll hear from 3 experts in the field: Dr. Peter Olumese from WHO, Dr. Kolawole Maxwell from the Malaria Consortium, and Dr. Francis Aminu from the Dangote Foundation. We will also be live tweeting the webinar today using the hashtag Integrating Malaria Nutrition, so please join us there as well. First, a quick word about GBC Health. GBC works with companies to leverage their expertise and resources to improve workplace and community health programs around the world. Our events like this webinar are platforms for the best minds in global health, development, and sustainable business to come together, discover unique insights, and forge meaningful and lasting partnerships. We'll also be announcing an exciting new initiative in Africa focused on private sector implementation and partnership during the UN General Assembly week, so stay tuned for that. Finally, a few logistical issues. If you connected through the Zoom link on a computer or tablet, you should be seeing a presentation with a slide introducing the speakers. At the bottom or top of your screen, you will see a black bar with 5 icons. The only relevant icon is the chat function. Clicking on the chat button will open a window that will allow you to chat with all participants or with an individual. If you're not seeing this, there's a small button at the top of your screen that will allow you to exit the full screen mode, and the chat should appear on the right-hand side of the screen. Please send any logistical questions directly to the participant marked host. It's my colleague Margaret Arbogast. Questions for speakers can be shared either with everyone or with the host directly. The Q&A session will come at the end of all of the presentations. So without further ado, let's get to the webinar. I want to introduce my colleague, Ms. Ochuko Keyama Onige. She'll give a brief overview of our CAMA program. Ochuko, over to you. Good morning.
Hello.
Ochuko, go ahead. We can hear you loud and clear.
Okay. Thank you, Ian. I appreciate the introduction. It's great to be speaking with you all today. Thank you once more for joining us. Before we proceed properly into the presentations, like Ian said, I'll give a brief introduction on CAMA. Hello? Hello, can you hear me?
You're good, Ochuko. Keep going.
Okay, so CAMA is the Corporate Alliance on Malaria in Africa. Is a unique coalition of companies from various industries, all with business interests in Africa. And it's currently an initiative under GBC Health, but was formed by Marathon Oil in 2016. And is currently co-chaired by Chevron. CAMA channels the voice and competencies of the private sector to drive impactful partnerships for malaria control and elimination in Africa, starting from the workplace workplace program to communities where companies are working and countries in general. And we recognize that the assets of the private sector are valuable in the fight against malaria. Our areas of work includes convening and building in-country capacity. We do this via organizing workshops, events, trainings, conferences, bringing key stakeholders together to dialogue on the issues on malaria and provide solutions towards malaria elimination. We've had specific projects in several countries over the years, Southern Africa, Kenya, Ghana, Angola, and currently in Nigeria. We catalyze multi-sectoral partnerships to increase the scale and impact of malaria control initiative in key priority countries. We believe that no one stakeholder can do it alone. The government, the private sector, and everyone is actually part of the fight against malaria, and we all must come together to do this. So partnership is like the bedrock of what we do. We provide visibility for companies and private sector that are into malaria prevention and control via our communication and media platforms and awards, events, and case study publication. We do advocacy and creating awareness on malaria programs and exchange of knowledge, like what we're doing right now, teleconferences and via our global policy and dialogue platforms. So some of you already know about CAMA, but not everybody on the call right now. CAMA is a membership-based alliance. Our members currently include Chevron, Access Bank, Dangote Foundation, Nigerian breweries, Syngenta, Sumitomo Chemical, the cuts across the length and breadth of different sectors, oil and gas, agro-business sector, and banking sector and the rest of it. They are champions at the forefront of fighting malaria. Their activities spans the full spectrum of public health interventions, from development of products to fight malaria, implementation of vector control measures, provision of treatment for their employees and communities where they work, and even making investments in institutions such as the Global Fund and Rollback Malaria Partnership. So we have a diverse group in the alliance already, and participation is open to all companies that share our commitments in the fight against malaria. In today's webinar, we will discuss two major health problems that is affecting our world today, especially in sub-Saharan Africa. One of, especially amongst children and pregnant women, malaria and nutrition. Malaria, majority of us know the challenges and the burden, the impact of malaria in our continent and in our world, but because it's highly talked about, unlike nutrition. And so we want to use this opportunity to highlight both issues, talk about the linkages between malaria and nutrition, the impacts, the challenges of tackling these issues, and the need for an integrated approach to program delivery. We've often than none, we do things in silos and programs vertically, but we want to try to see how we can do an integrated approach. And I believe that through that, we'll be able to save more lives. I will end with this quote, which is from Dr. Pedro Alonso, Director, WHO Global Malaria Program. He said, the most effective way to reduce deaths in fragile states, especially those facing malnutrition, is by boosting malaria prevention and control. Both diseases often feed off each other. And I believe from this line, we can see that it's a good platform to actually start our discussion and to ensure that we get to our desired goal of integrating programs in global health. Now, without further ado, I will turn the time over to Dr. Peter Olumese of WHO to tell us more about our discussion today. And feel free to send me questions regarding to CAMA and the work that we do. And when we get to the Q&A session, thank you all.
Thanks very much, Ochuko. I'll just introduce Dr. Peter. Dr. Peter is the Medical Officer for Prevention, Diagnosis, and Treatment in the Global Malaria Program at WHO. He has been a medical officer with the GMP department since 2001. One of his main products is the WHO Guidelines for the Treatment of Malaria, now in its 3rd edition. Dr. Peter has been a pediatrician and clinical pharmacologist for more than 24 years, and he has served as co-chairman of the Rollback Malaria Country and Regional Support Partners Committee, formerly known as the Harmonization Working Group, since 2009. Dr. Peter will speak to us about Linkage's challenges and recommendations for integrating malaria prevention and nutrition. So Dr. Peter, without ado, over to you.
Thank you very much. Good evening, good morning, good afternoon, everyone, depending on where you are in the world. Very briefly, I am looking at linkages, challenges, and recommendations. Chuko had already talked about the malaria, nutrition, and the reasons why we should be working together. I'm not going to go into the technicalities of the diseases, but just to spend time to show that we can actually work together, harness things, and work within the health sector to ensure that we deliver optimally in terms of reaching those who are affected by malaria and undernutrition. As a background, malaria, malnutrition, anemia, they are key public health challenges particularly among the pediatric population. they contribute significantly to childhood morbidity and mortality, especially in sub-Saharan Africa. It's been noted that malnutrition is the underlying cause of over 50% of child death. Most times when they show statistics as to the leading cause of death in Africa or sub-Saharan Africa or in countries, you see malaria, pneumonia, diarrhea diseases, low birth weights, and things like that. I just want to state here that malnutrition, it's an underlying cause for most of these. So though you may not see malnutrition listed as standalone, but in all of these diseases, malnutrition plays an important role because it interrelates synergistically with other infections. Malnutrition increases susceptibility to infections, and episodes of infection in turn precipitates nutritional deficiencies. They tend to affect similar age groups, usually children under 5, and there's some sense of seasonality. The acute episodes of malnutrition tends to be more during the rainy season, the same period where malaria cases tend to be increased. And so it only stands to reason that in terms of delivery mechanisms of tackling these diseases, they are similar in terms of systems, in terms of personnel, be it facility-based, be it community-based service delivery and mechanisms. And so there are ample opportunities to harness and to work together when it comes to these two programs. Next slide, please. I decided to put this here just to show that it's bad enough that malaria and nutrition or malnutrition is a leading cause of death, morbidity, and mortality. But sometimes the operating environment, the challenging implementation environment actually makes this worse. We hear about a lot of humanitarian crises, fragile settings, complex emergencies, epidemics, and in all of this, just sets the stage for increasing childhood mortality and morbidity related to malaria and malnutrition, because they are displaced people moving from areas where there are very little transmission to areas of high transmission, access to health services and access to the food and nutrition becomes a major problem in these complex environments. Next, please. Very briefly, malaria affects about half the world population at risk. But my emphasis here is that it's highly concentrated in sub-Saharan Africa and amongst children. 90% of the 212 million cases estimated in 2015 from Africa, and 92% of almost the 500,000 deaths in Africa, and 70% of these in children under 5. So malaria is estimated to be the fourth highest cause of death among children in Africa, and that it claims the life of one child every 2 minutes. And this is made worse when you have malnutrition as an underlying cause. Next, please. These maps are just to show again the linkages between these morbidities. I'm not sure if you can see this very clearly, but just to show the inverse relationship between the level, or to show inverse relationship between poverty and malaria. In the map on top, the darker areas actually show is a reflection of the malaria confirmed cases per 1,000 population. So for example, the very dark areas, you have more than 100 malaria cases per 1,000 population. And when you come down to the map below, and the darker areas actually show a percentage of populations living under $2 per day. So the darker the area, the less the level of the GMP per capita. So in essence, malaria is not just a health issue. It's also related to the standard of living, the access to services, access and the ability to access those services. And certainly this is intricately linked with malnutrition. Next slide, please. I don't intend to speak to all of this. These are comprehensively the interventions we have right now for malaria control. But I have highlighted some, and I'm going to use one of these as an example to show how we can possibly integrate malaria prevention with nutritional services and nutritional rehabilitation. I will use the seasonal malaria chemoprevention as an example. But of course, diagnosis and treatment, case management in health facilities through the community case management, ICCM, these are all opportunities that can be used in terms of service delivery. But from my next slide, I will be concentrating on seasonal malaria chemoprevention. Commonalities, similar target populations I've talked about earlier on, seasonality, both in malaria and undernutrition in highly seasonal, peak rainy season, high burden of both malnutrition and malaria. West and Central Africa, estimated that about 1 million children under 5 die from causes related to malnutrition, contributes to 35% of all child deaths in the region. Malaria is the 4th highest cause of death among children. And in areas where that are eligible for seasonal malaria chemoprevention, it's estimated that about 39 million children live in this sub-Sahel region, and certainly in reaching them, you also targeting the same population where you have a high burden of malnutrition. Next, please. What are the opportunities? Can integrate nutritional screening, referral of identified cases of acute malnutrition as part of the SMC outreach, provision of food supplements, integration of the BCC activities, educational activities to mothers to improve the rate of early and exclusive breastfeeding, the rate of seeking care quickly enough, and having access to health workers. Next, please. Just keep going. Okay. Also highlighting what I have just said in another way, if you look at the nutritional interventions, for example, the infant and young child feeding program, micronutrient program, the SMA program, and look at the target age group. This is the same age group that we target for seasonal malaria chemoprevention, be it complementary feeding, children less than 23 months of age, supplementation of vitamin A, less than 59 months of age, zinc, less than 59 months of age, and so on and so forth. And for seasonal malaria chemoprevention, our target is children below 59 months of age. So we are essentially targeting the same group of children in the same geographical area, and with the two disease conditions that have the same similar seasonality. Next, please. Why integrate health services? An effort to move towards reduction of missed opportunities and provision of a continuum of preventive and curative services. I think most times when we run parallel programs, we tend to be targeting on the disease rather than the child. And I think we would maximize our interventions and have maximum benefit if we look at the sick child rather than just looking at one particular disease. And every opportunity that a child has to make contact with a health worker should be maximized to meet the entire need of the child. Sustainability, long-term focus. Vertical programs would usually provide a short-term solution. When the projects end, that's it. And to allow countries to make this program sustainable, we need to harness and work together in a concerted effort. Harness efficiencies and effectiveness of countries' preparedness effort to reduce malaria. A lot of activities in countries have been going on for the past almost 10 years with the advent of the Global Fund. A lot is going into malaria. They're getting resources, partners are investing in malaria, and I think it's an opportunity to also add other interventions, and this will be maximizing efficiencies in terms of moving forward. Next, please. But there are certain things we need to consider if this must work. One is collaboration. These are two disease programs, and sometimes they may be in different departments or different units, even within the Ministry of Health. So they need to plan together. They ensure that there is no funding imbalance. These interventions are heavily seasonal. So we want to ensure if resources are coming from various partners of various other parts of the ministry or government, they have to come at the same time so that there is no misalignment of investment. Government ownership, advocacy, prioritization to ensure that both programs work together. If it means setting up a task force, then that is important. The programs must speak to each other, they must plan together, the technical partners must work together to ensure that things are done in sync and on time. Next, please. Referral systems, usually, especially in the very peripheral areas, there may be need to refer patients, to refer the children. We need to ensure that we are building robust health systems and robust referral systems, and that the community health worker is equipped to know when to refer and enabled to make those referrals happen. Supply chain system. We cannot have parallel systems. The food supplements cannot be coming at a different time schedule from the drugs for the SMC. So all of this would need integration and working together, planning well ahead in terms of investments, in terms of the delivery mechanisms, in terms of how do we monitor and evaluate, how do we put a surveillance system in place. All of this would need to be integrated for the delivery to be maximized. Next. Very briefly, I think in my last couple slides now, of course, there are lots of advantages. We avoid missed opportunities on comorbidities, like I said earlier on. Any opportunity for a health worker to have contact with a sick child, that child should have the benefit of having a comprehensive package rather than just one disease being treated, same age group. And some of these things are relatively simple that can be delivered at the community, even in complex emergency situations. Very little is required to make this, be it a door-to-door delivery or a fixed point delivery. They can certainly be integrated. And of course, this continuous screening will reduce levels of malnutrition because the health education, opportunities to provide health education, to provide preventive interventions rather than waiting for the severe acute malnutrition. However, there are challenges. We need to train the staff and supervise activities. You do not want to overburden the health worker. We want to ensure that integrating nutritional services with malaria would not lead one or the other to lag behind. So we need to ensure that we make work easy for the health worker. Need to specific, you don't want a lot of paperwork. Otherwise, it burdens things and makes things go slower. We need to ensure the supply and the staff at the health center at the same time, and financing, like I talked about earlier on, has to be synchronized, even if they are coming from different partners and different sources. Next slide. So in conclusion, in the Sahel region is a region where child malnutrition rates and high seasonal malaria coincide geographically and seasonally. Policies and systems exist to improve efficiencies of delivery of life-saving interventions through integration, and combined strategies can increase coverage of integrated child preventive packages. However, effective integration requires joint planning and synchronized resourcing and implementation. Detailed cost analysis of the different programs also essential for effective implementation. And importantly, country ownership is the bedrock for success and sustainability. As long as we run these as projects, they would end. We need to make them programmatic, and they need to be country ownership. What we want to do, we want to strive to end preventable deaths. We want the children to thrive, to realize the highest attainable standard of health, and to achieve transformative and sustainable change. And I think this is my last slide. Thank you very much.
Thanks very much, Dr. Peter.
Yep.
You highlighted a number of important things that hopefully we can get back to in the Q&A session. You highlighted the importance of collaboration and making sure the approach to treating children is coordinated and coherent. This includes the private sector and the work that they're doing on both of these issues needing to link into these other systems. also some opportunities potentially for the private sector to support on supply chain issues and coordination and planning. So a lot of really good stuff to dive into there. A reminder, using the chat function to please submit any questions you have to the speakers, identifying the speaker as well, and we'll try to get to those in the Q&A. I'm now turning to Dr. Kolawole Maxwell. Dr. Maxwell is a community health physician with experience in planning and managing health activities at community, facility, and policy levels. His experience also includes working with a range of multilateral and bilateral donors, central governments, national implementing institutions, local authorities, NGOs, and international and local consultants. He's currently the West Africa Program Director for Malaria Consortium. Dr. Maxwell will speak to us about the Malaria Consortium's experience on integrating management of malnutrition into other childhood illnesses, including malaria. Dr. Maxwell, you are very welcome.
Thank you very much, Ian, and hello to everyone. I would like to first thank Kama for inviting me to share few of our experiences in Malaria Consortium in integrating management of malnutrition into management of other childhood illnesses. Throughout this presentation, I've structured it, next slide. I've structured it to give you a little bit of background, overview of some of our integrated projects, make some conclusions, and then one or two recommendations for future. Next slide. A lot of us, if we are listening from Nigeria, some of this information I've put on here will not be strange to us, in the sense that the burden of childhood illness and malnutrition in Nigeria is high, especially for children that are under 5. And you can see the statistics that speaks for itself. In addition to this high burden, the access to basic healthcare services is also very low, and the proportion of the budget this year for at the national level for health is also an indication that it's around 4%. Within this low access is hidden also a very high level of inequity, in which people that actually need the services are not getting it, and where the services are people that probably doesn't need it as much. Next slide. There are many, integration of health systems mean many things to many people. But for the purpose of this presentation, I would like to guide further presentation by definition from WHO, which is basically the organization and management of health services so that people can get the care they need when they need it in ways that are user-friendly, achieve the desired result, and provide value for money. And there are very specific, important words within this definition that will be relevant as I move along this presentation. Next slide. Some words I would like to say that integration itself is a continuum and is not the extreme end of a spectrum. So we will start small and gradually work towards better integration in any implementation of integration. And when we talk about greater value for money, we mean this in the usual dimensions, which is economy in terms of the cost, but we also mean it in terms of efficiency of the services and the supporting systems to support these services. And we mean it in terms of as well the effectiveness in terms of the impact of the burden of these diseases and malnutrition that we are targeting at. We also need to recognize that the different types of integration will be different at different levels of health care. We're talking about the primary level, the secondary level, and the tertiary level. And as I said earlier, the focus of this presentation will be at the community level, in which Malaria Consortium has experience in implementing integrated childhood case management of malaria, pneumonia, and diarrhea. Next slide. Next slide. So the first of our project that I would like to share with you, next slide, is the project we implemented in South Sudan. Is a project, is an ICCM project that had integrated into its community management of acute malnutrition. But we also know about South Sudan that the burden is equally high like Nigeria, and in terms of the child mortality, under 5 and infant mortality, but also general acute malnutrition and severe one. In 2009, the country introduced management of community-based child survival programs, and MC commenced the implementation of ICCM. But in 2013, management of malnutrition was integrated into the ICCM. Next slide. The structure that we use for that project in terms of the delivery of the project is what I try to show in this table, where at the community level, the arm that is providing the services for the people are different community-based health workers, while the community-based distributors are delivering the services of malaria, pneumonia, and diarrhea. We have community nutrition workers and community nutrition assistants delivering the CMAM services, while the community mobilizers are mobilizing for both set of services. MC recruited supervisors that we call field officers to oversee and ensure that these two programs are well implemented. But the supervision from the government side for the nutrition is by health workers that are stationed at the OTP sites, while the community-based distributor supervisors are overseeing the CBDs that are providing malaria, pneumonia, and diarrhea services. And at the ISM level, at the community level, we have project officers that are providing oversight and ensure that these services are run as planned. Next slide. In the next slide, I'll just share with you the results of that project, and you can see that the coverage of the project gradually increased from 2013 to 15, and the number of defaulters gradually reduced. But you will see a sharp increase in 2014, and one of the main reason for that is because of the outbreak of violence in South Sudan. As we know, South Sudan, there are a lot of fighting going on within that country. But despite that, if you look at the coverage of CMAM, it gradually increased over this period. And this is a testimony to some of the things that we are seeing in terms of integration of services. Next slide. The key findings is that, in summary, bringing ICCM and nutrition together has shown to improve delivery and increase in coverage of nutritional services, which is one major thing you really need to watch out for while integrating, to ensure that both services all the services that are being integrated together does not, one is increased and the other is affected negatively. The second bit is that referring children to OTPs that are strategically located in the community is a key feature. We moved most of the OTPs that are set up into the communities, and these are led to a high recovery rate of children admitted with severe acute malnutrition. Next slide. For future programming, we feel that we need to continue to strengthen the ICCM and nutrition connection and improve training and supervision of field staff while we are following up with referral afterwards. Next slide. We have a small project that is starting in Nigeria. It's called RISE Project. And this is a pilot project that is being implemented in 2 LGAs in Niger State of Nigeria. As we all might know, ICCM implementation started in Nigeria in 2013. And this pilot just started, as I mentioned. And this RISE project is being funded by Eleanor Crooks Foundation, and we are on that project with IRC as the prime. Next slide. This next slide, I just show you the logical framework of the project. You will recall that the design of the delivery arm of the South Sudan project as the deliverer of the services of the nutrition is slightly different from those that are going to be delivering the pneumonia, the malaria, and the diarrhea services. Whereas in this pilot project, we'll be looking at the community health workers that are delivering the ICCM services to be those as well that will be managing the children with uncomplicated severe malnutrition. And you will see the objective of the project and the clear results that we are expecting to get out of the project. Next slide. But we would like to know that Malaria Consortium also has other projects apart from these two that has some elements of nutrition activities integrated into them. They are all our ICCM projects. Most of them focus on screening of acute malnutrition using mid-upper arm circumference tape and referring these cases of malnutrition, while some of them also provide infant and young child feeding advice for children with moderate acute malnutrition for those at risk. And this project has scattered in all our locations in Asia and Africa, talking about Myanmar, Mozambique, Nigeria, South Sudan, and Uganda. Next slide. In conclusion, I would like to state here that from our experience, we know that the integration of nutrition into management of other child illnesses is feasible because we've done it and we've seen the results in cases where this integration has happened. But we also like to send a note of warning that we should not integrate for integration's sake, and it does not mean that we have to integrate all into one package. And it is really not a solution to inadequate resources, because although some money can be saved, but at some point there might be need for additional investment into the supporting health systems for the integrated services to provide the quality that is desired. Next slide. In terms of recommendations, as I earlier said, there might be need to gather more lessons learned on possible various enabling factors that encourages integration and possible entry points for that one can pass through depending on the services, depending on this context and scenario one found themselves. But we also need to explore and pilot innovative approaches, like working with the private sector, recognizing that private sector are different types. We have philanthropies that could fund, we have private sector that could produce and market health commodities that is required to deliver those services. And we also have private service providers that could actually participate in delivering these services. And lastly, I would like to recommend that there's need for us to start looking at the value for money of integration of ICCM into nutrition. I'm talking about what I mentioned earlier in terms of reduction of burden of these two diseases on the children. Next slide. So the key message is I would like to share with us at this presentation are three. As I said earlier, the integration is feasible in Nigeria, and we have lessons that we can use to scale up in Nigeria. And it's very critical that once we scale up in Nigeria, the lessons that we generate from Nigeria is so essential for scaling up this integration in the entire sub-Saharan Africa. Next slide. I just want to share access to more detailed information about all these our projects with you, and at your leisure time, you could access these resources and learn more. Thank you very much.
Thank you, Dr. Maxwell. Great presentation. In addition to your highlights, I want to highlight that the thing you said at the beginning of your presentation about integration being a continuum. Important to know that you can start small and build in new elements gradually. I think with sort of the siloed approach that we've had for many years, it can seem daunting to jump onto this integration agenda with 2 feet, as you say. So thanks again. We've had a few questions coming in, both through the direct chat and the chat to everyone. So I'd encourage everyone to continue to submit questions. Hopefully we'll have time for a few at the end, even if we run over a few minutes. Finally, last but certainly not least, we'll turn to Dr. Francis Aminu. Dr. Francis is the Director of Health and Nutrition at the Aliko Dangote Foundation. He is a development nutrition specialist with more than 20 years of professional and cognate experience in program management and organizational development in nutrition, food, and health systems. He has proven experience working effectively with various stakeholders, including government officials, donor and development agencies, civil society actors, and clients with in-depth knowledge of the political, economic, and sociocultural characteristics of Nigeria and other African countries. Dr. Francis, looking forward to hearing how the Dangote Foundation is approaching this challenge. I will send it over to you.
Yeah, thank you so much, the moderator. Thank you for the opportunity for actually granting us to be part of this and to actually see how we can actually deliver interventions that we all know are proven very, very successful. And we have just listened to my colleagues, Dr. Maxwell, from their experiences in Sudan and in some parts of Nigeria. In the same vein, we're trying to look at this, and especially even starting from nutrition point of view. Can you move us to the next slide, please? Just to give us the big picture, although we have listened to so much of undernutrition or malnutrition being an underlying cause of child death, we try to look at the prevalences and causes and most of the intervention and how Aliko Dangote Foundation is trying to approach this. The next slide. Yes, we know this, where and how many children die all over the world, which is still very real and fresh in our memories. About 6 million children are still, we find them dying every year, and about 17,000 every day. When you look at that, that's really huge. We're talking of several several planes carrying children and dumping them somewhere, and that we could not see them again. And that is the kind of tragedy we face with globally. And those countries that are contributing as well, really very, very important. Almost 95% of this child death are from 75 countries, and you could see them in red as shown in the other map. Next slide, please. And when you look at this, what is important here is that whatever the cause of the death, children dying, we are saying undernutrition is a major underlying cause. When we say it's an underlying cause, it's saying we could have prevented, just like all my previous colleagues have also mentioned, that when you look at these deaths, you could have reduced half of these children from dying if we have taken very good care. And that's where we, just like my colleague Maxwell said, we have to be careful when we are now integrating, because we could miss opportunities. And I think that's what the first speaker said. If we don't then look at it, at that child suffering from the same ailments, the same child having these all through, and then now having undernutrition, then we could miss a lot of opportunities of actually saving lives if we don't approach it in an integrated fashion. Next slide, please. And this is just the situation in Nigeria. this is well known to all of us, that we're having really huge number of children, and as presented my colleague, I won't bother you much. But again, you will see from the maps that I've just shown, for all indices of malnutrition or undernutrition, we're talking of the northern part of the country actually contributing more to the burden of undernutrition, the burden that malnutrition is actually bringing about. And if you look at even wasting, that what we are having currently is more than the emergency level that WHO set. That means, and that is why even the government of Nigeria, Ministry of Health, has alluded to the fact that they declared malnutrition an emergency situation in Nigeria. The next slide. And there's no way we can actually act and tackle this if we don't look at the critical causes, major causes of undernutrition. Because nutrition contributing to child death or health, in the same vein, is contributing to other development indices we are talking about, like economy. We know that the proportion of GDP that will be lost. So it's contributing as well to what we call learning outcomes. And that is why even banks today are talking of gray matter infrastructure, trying to see how we can improve cognitive development. But when you look at these at various levels, which has helped us to actually look into those interventions that we're talking about, nutrition-specific interventions and nutrition-sensitive interventions. And that is what we mean when we say we are integrating. There are some priority interventions that are very, very important. I remember in the past when we're looking at those key priority nutrition actions, what we call essential nutrition actions, that have about 6. Now today we have some of those actions that, yes, call them whatever name or other, whatever kind of definitions you want to give or categorization you want to give, they all still tell us that there are some priority nutrition actions that could be carried out. And that's what this framework is actually bringing about. And you will see the issue of malaria control, management of malaria, and other infectious diseases are very, very critical in actually attaining improved nutrition in any society. The next slide, please. Now, Dangote Foundation's response, when you look at it, the vision of Dangote Foundation is a vision of a man that is actually believing that we can have our people healthier and better educated and empowered, and is providing a shift for the first time, and then more or less at least new, one of the first in the series of Africans, a shift towards African helping Africans, and sometimes Africans helping the whole world. That's the way we're looking at it. And it's trying to look at it, looking at 4 pillars. Pillars of health, and then issue of economic empowerment, issue of education outcomes, and again, not losing sight of the fact that there are a lot of emergency situations moving around, roving around the whole world, affecting and causing more of undernutrition and even increasing the burden that we have from all these diseases that we're talking about, like malaria and other infectious diseases. So it's looking at this holistically. But again, when you look at all those key pillars, undernutrition is very, very critical and central to any intervention that you may want to carry out and look at in that regard. Next slide, please. And that is why we came up with a program we call Aliko Dangote Foundation Integrated Nutrition Program. Integrated in the sense that, yes, it's going to be stepwise, not just lumping everything together for the sake of integration. But again, we are starting from the fact that Nigeria, for instance, we're having those challenges as we have actually portrayed about children that are suffering from severe acute malnutrition, and we're going to use a community-based approach. We're targeting about 1 million children. Like I said, this is a project or a program that is being designed, and we finally by the end of this month, we definitely have, we're going to start the rolling out. And I'm happy to announce here too that Malaria Consortium happens to be one of our strategic partners in implementing this. Then, apart from looking at severe acute malnutrition, because this is a point of entry for us to get into the community, we realize the fact that once a child is malnourished, such a severely acute malnourished child is a proxy to a very vulnerable household from whatever community. And when you go to such a household, you will find out that they are those that contribute to the issues around water and sanitation challenges, issues around poverty, issues around food insecurity. And if you look at their livelihood, they have none, virtually none or less livelihood as compared to other areas. And that is why we're looking at that. And again, we have to get government to do what this government is supposed to do, the business of providing leadership and governance for issue of nutrition and other disease management, and then at all levels. So we need to do that. The next slide, please. And then I've mentioned this. These are states where we are working in the north, and you could see the contribution to overall malnutrition from the country. In those 13 states that you are seeing in both red and the pink picture, we're talking of almost 7 million children out of about 11 that are stunted in Nigeria are from those regions, even in those 13 states. The same thing with the acute or wasted children, as earlier mentioned. If you look at poverty incidence, it's over there, access to improved water, access to improved sanitation. These are issues that this program is actually going to address. Next slide. And this is how we are going to address this. We're all aware of community management of acute malnutrition. Everything we're talking about is going to be community-based, and that is where we have the assessment. We have the services that will be provided, especially for addressing the severe acute malnutrition. But what is different here, this is just the standard ways of addressing malnutrition. But what is different here is that we're going to link a child to the household, and then at the household level, you now have those behavior change interventions that will address the issue of infant and young child feeding, the issue of water and sanitation, the issue of livelihood and economic empowerment, because at the end of the day, the environment in which the child who is malnourished is situated or located matters a lot to us as well. So it's not enough to just provide RUTF or plumping nut and then the child is okay, and then we'll go back to that same environment that predisposed that child to it. And then in a nutshell, you find out that this is enclosed by what we call the nutrition leadership and governance support system at all levels. And then we have monitoring, evaluation, accountability, and learning throughout the whole process. This is a 5-year project that we would like to look at what will happen in the next 5 years to reach the 1 million children. The next slide. Well, this is just a kind of an expansion of what we mean by the integrated management and what are those key interventions and where we actually see malaria. In standard CMAM, we just provide RUTF and in most cases ORS, but never do you have malaria prophylaxis being considered as well. But in this regard, while the child is being treated, we definitely have to consider malaria prophylaxis. And when they are followed through to home, we still have to look at the issue of seasonal, as we have mentioned, which Malaria Consortium has an experience in, seasonal malaria chemoprevention, which will follow, and even along with the IYCF counseling, and then the issue of BCC for the use of LLIN, and then other issues that have to do with child health services. These are interventions that will be integrated and will be followed through. So that's just the kind of schematic diagram of what we follow to get to that child being recovered fully from severe case of malnutrition, as well as those who are even at the borderline. So they are still captured, and then through counseling and referral for appropriate health interventions, their needs are met. And then we talk of the nutrition leadership and governance, and the monitoring, evaluation, accountability, and learning throughout the whole program. Just to add finally here too, that we envisaging having strategic partners. Like I said earlier on, Malaria Consortium is one of the strategic partners we are having, and they work directly with NGOs. This time around, NGOs' capacity will be built as well over this period of time, where they will know how to even make assess grant, how they can write proposals, how they can implement and deliver services at that level, what they are known to do better. So we are envisaging that happening in the next couple of years. So it's going to be community-based, like I said, and with all these interventions taking place at the community level. Thank you very much for the opportunity given to me to just give you the highlights of what we are planning to do. Thank you for listening.
Thanks very much, Dr. Francis. Very much appreciate your contribution and that of the Dangote Foundation to this work. I want to emphasize something you said that the other presenters mentioned as well, the importance of priority interventions at the right level. And you made a distinction between nutrition sensitive and nutrition specific actions that can be taken at the different levels. For those of us on the phone to learn more about that, obviously check out the WHO website. The SUN Scaling Up Nutrition Network also has a number of resources for the private sector as well on these issues. I also very much like your sort of framework of using nutrition as a proxy for understanding the challenges of individual vulnerable families. So I think that's an interesting framework to explore. We are coming to the end of our time. There have been a few questions that have come in, so I will extend maybe 5-10 minutes for those of you the participants that want to stay on to ask a question of each one of the speakers. First, I'll go back to you, Dr. Maxwell. A question came through that's asking, and actually I'm going to switch it around. The question was around what are the malaria services that were added to the ICCM programs, but maybe you can talk about some of the malaria services you already provide on the programs that you discussed, and then maybe what nutrition services were added. Dr. Maxwell?
Thank you very much, Ian. We, on ICCM project, as the name is integrated community case management. So all the full range of case management of malaria, uncomplicated malaria is provided at the community level. And here I mean diagnosis and treatment of uncomplicated malaria at this level.
Thanks very much. And in terms of your nutrition approach to adding, which nutrition services do you provide?
Yeah, also for nutritional services, we are providing the aspect of screening using the mid-upper circumference to and referral of minority cases. We also provide some services around nutrition advice for those that are mildly malnourished. This is in addition to the management or community management of acute malnutrition, as I mentioned in that project of South Sudan.
Thank you very much. I appreciate that. Hopefully that answers the question. If I can move back to Dr. Peter quickly, appreciate your patience as the other speakers were talking. Why are countries or programs not currently maximizing opportunities for integrated delivery in your experience?
Yeah, well, I would say because the programs have been running in parallel. They have not really, from a programmatic perspective, start to plan together, even within the same ministry. Most of these programs have been running as projects. We have partners coming to run these individual projects, but I think if we want to make the best out of this, we need to bring it back to the programs and work with the programs, because at the end of the day, we end up training the same health worker on different things by different partners, and which is not very helpful. Yeah. Rather, we put it and to integrate and see this as an extension and part and parcel of the overall health system.
And in your mind, is it's sort of the government's role to convene these partners, or is the WHO working with the governments to try to do this?
Well, it doesn't matter who initiates. And for example, we've heard about the Dangote program, which I think is very laudable. A lot of things planned and a lot they can deliver. But it's a great opportunity for them to liaise with the malaria program, things like that. It doesn't matter who, because these are partners. But certainly, the government has an oversight whether they are delivering directly or not. But it doesn't matter who. But I think everyone who is a player here has a vested interest to make this work. And whosoever has the leverage should encourage and move others and take the lead. Then we would have practical examples to share and to encourage others to follow.
Thank you very much, Dr. Peter. Appreciate that. One final question for Dr. Francis. There's a question about just a little bit more interest into the strategy of the Dangote Foundation. Can you talk a little bit more about how, a little bit more of the tactics around the strategy for reaching the 1 million children? Are there sort of target states, LGAs, that you guys are looking at within Nigeria? You've mentioned the Malaria Consortium, obviously, but are there other sort of planned roles for other partners?
Yeah, thank you. So I think, yeah, thank you so much. I think I highlighted in what I said that we're going to work with strategic partners who have experiences in actually community-based programming, malaria, nutrition, and then even combined work with them. We're going to work in 13 states. Those 13 states are northern part. The two major geopolitical zones in the north, northeast and northwest. They have 13 states in north. So we're going to work in states, and in each LGAs, we're going to work in at least 10 LGAs where we're envisaging will reach out to about 20,000 children suffering from SAM, and then again, I mentioned too that underlying that is the fact that we're going to work with CBOs, including LBOs, at the community level, because they are involved with one development or the other. So we're going to work with them for effective service delivery, but supervision of the strategic partners and with their experience as one of those partners we are working with. And we have linkage, some categories too. We call linkage partners. These are the ones that will leverage with what we are doing in terms of medical assistance especially for the livelihood issues or the issues of income and other part of. And then this program, Aliko Dangote Foundation, has not implemented any integrated malaria nutrition program. But for the first time in this, we are actually including both malaria and nutrition and other infectious diseases. It's not just that, because we are saying we're targeting the child at the end of the day. So anything, any obstacles that you need to remove, any bottleneck you need to address to get to that child is what we are actually looking at in this regard. Thank you.
Thank you, Dr. Francis. And I certainly hope that you count CAMA as one of those strategic partners. So given the time, I think we'll have to leave it there. I want to extend a warm thank you to our speakers and especially to the participants. There will be, as some of you have asked, a video presentation as well as the deck and takeaways emailed to you if you RSVP'd. They will also be available on our website within a few days. Please don't hesitate to reach out if you have any additional questions or would like to connect with any one of the speakers directly. Thanks again for your attention and have a great rest of your day.